So I'm going to share my slides. And for those of you just joining us, if you could introduce yourself in the chat with your name, organization, pronouns, and role. We are going to be talking about strengthening emergency department and substance use treatment linkages. And we're celebrating 10 years of linkages together. So really just being appreciative and grateful for all that you've done with us together in the last 10 years. Our plan for today are to share best practices in emergency department linkages and supporting people with active substance use. We have some special guests to talk about that. And we'll use what we learned to determine how we will strengthen these linkages. We've done our introductions, and thanks to Manuela, did a beautiful healing practice. For the next 5 minutes, I'll be giving you some updates. And then we have some special guests talking about ED linkages and substance use supports, and I'll introduce them in a few minutes. And we'll be talking about some cases, both successful and still challenging cases, which you can actually bring into the breakout groups to talk more about with each other, and also to discuss your own cases, your questions, and best practices with each other. Then we'll come back to the large group and share highlights. For those of you who are new to East Bay Getting to Zero, our mission is to get to zero HIV stigma, zero health disparities, and zero HIV transmissions by advancing health equity and healing. This is us before the pandemic. Many of you have been part of writing our 5-year strategic plan, and we are really focusing on 2 of the 5 priorities today, both improving collaborations, because linkages require lots of strong collaborations, as we've been learning, and innovative models, because part of innovative models is testing everywhere. And so universal testing in the emergency departments will bring access to HIV testing and STD testing to more folks who are not already engaged in care. So really focusing on these 2, and mixed in with that will be youth engagement and housing, as you'll see. For those of you who want to download the 10-page strategic plan, you can see the link here. It's also in your handouts. So since in April, we got together and did a workshop on improving collaborations, and we got some really useful feedback from you all around how to improve our online service directory, because coordinating and contacting each other was a big priority. So we now have new Google Maps and directions, so it's more user-friendly and colorful. We have a simplified search result, so you can see here, you can see a lot more of the key information. It's more organized and clear. We have print options, so you can print to paper or to digital PDF. And also you have live links, so people on their mobile can click on these links and call directly or email our organizations directly. We also added a photo option, so you can send us photos of your team, your logo, whatever you want that you feel like would be useful for people to see around your organization. You can send to us and we will post it on here. So before you finish up this workshop, my ask for you is to make sure your listing is up to date. So ebgtz.org/services. Most importantly, make sure your phone number and email is up to date, and that it actually goes to a real human being who will pick up or respond the same day, because you all know how frustrating it is when you're trying to reach an organization urgently and you can't reach somebody who knows what you need to know. So please make sure your phone numbers go to somebody from your team or somebody who knows your team pretty well, and the email address as well. So those are the most important pieces. If there are any updates or edits, please email Jessica. You see her email down here, jessica.price@ucsf.edu. And you can also send her photos that we will add here. So thanks to all of you for your feedback. It is now in our live new service directory. We are also celebrating 10 years of linkages this month. In 2011, Georgia Schreiber, whom a lot of you know and love, who is now full-time deployed to COVID and could not join us today because of the surge. She brought up a group of us together 10 years ago and said, hey, I have this big long list of people who are out of care. What's up? So we did a deeper dive into the data and found thousands of people, in fact, were not engaged in care. And so in 2013, we pulled together our first large network meeting. And during that meeting, Bronze Courtney from HEPAC inspired us to have single points of contact in a list and develop a warm handoff protocol, which is now our online service directory and some of our shared rapid linkages. Since then, we've also gone through some universal testing and PrEP launches, as well as implementing rapid linkages and rapid ART countywide and region-wide in both counties, Contra Costa and Alameda. We've also done trainings on racial bias, sex positivity, motivational interviewing, and trauma-informed care, because we know that these skills are really important in engaging folks in care. We think that this has had a positive impact county-wide, regional-wide on 90-day linkages. You can see Alameda County improved 9 percentage points to 79% by 2017, and Contra Costa improved 10 percentage points to 92% for 90-day linkages. More recent data from HIV Access shows that our community health center linkages are still maintaining high levels at 94%, even through the pandemic. So that's really kudos to all of you for keeping up on our linkages and really figuring out how to connect with folks during this challenging time. I do want to say the reason we are together is because Highland Hospital, the emergency departments throughout Alameda Health Systems, and EDs everywhere face a greater challenge with patients who are not already engaged in care. And so 30-day linkages from the emergency department to the Alameda Health System clinic is only 59%. So that's why we're here today to figure that out together. The ED team also did a deeper dive into the 25 people not linked last year and found that 86% had active substance use disorders, 56% did not have phones, 24% had mental health diagnoses, and 12% were houseless. And so I would like to welcome now the ED team, the emergency department team from Alameda Health Systems. That's Dr. Doug White and Ashley Godoy, as well as Sunny Lai from the Alameda Health Systems HIV team, which is the adult immunology clinic. And following them will be Dr. Eric Anderson and Dr. Monish Ulal from the Bridge Clinic to talk about how to better support people with active substance use. So thank you. If you want to take it away, Doug.
Well, thanks for including us. It's really important for us to be, basically part of the team in terms of collaborating in Alameda County. For those of you that have never been to Highland, this is what the ambulance bay looks like. We're a busy hospital. We are trauma doctors. We deal with acute emergencies, but we're also a dedicated group of people that care about public health and disease prevention. And I've been at Highland for 20 years now, and we have been doing HIV screening for an awful long time. 2005 was the first HIV screening program that I basically brought to the Highland ED. And this is a picture of Jill, one of my favorite nurses, back when we trained 150 Highland nurses to do oral swabs and do real-time point of care HIV screening. This picture is a little bittersweet to me because, well, not only Jill is awfully young in this picture, shows us how long we've been doing it. She just told me yesterday that she's retiring. So we have basically been at this for a long time, and our program has evolved kind of year after year. And with that evolution, so has the way that we implement screening. And I wanted to walk you through kind of what our current mission statement is, and to show you how our testing protocol works. So this is our mission statement. The first three in dark are actually what we're doing, and the fourth gray one is what we hope to do in the next year. So first off, our goal at Highland Emergency, as well as the San Leandro Emergency Department, is to identify undiagnosed HIV in all patients who receive emergency care. That is the core of what we are trying to do. And obviously, integrated in that is to provide rapid linkage for everyone who's newly diagnosed, but also to link patients who face barriers to engagement and who need to be re-engaged to care. Because we know that we serve a vulnerable population, and many patients who get care through Highlands Emergency Department, we are their entryway into the healthcare system. And many of these patients have previously diagnosed HIV, but need to be relinked to care. And as of just a few months ago, we have now made it our standard practice to initiate immediate antiretroviral therapy for newly identified HIV positive patients. So that's something that we are gaining experience rapidly with. And then over the next year, we have a plan to basically bring HIV prevention services to both of our emergency departments with a focus on identifying patients who are at high risk for getting HIV, beginning PrEP, and then hopefully utilizing this type of network of care providers to basically do a handoff so you can do the heavy lifting with ongoing prevention and PrEP services. So this is what our current screening program looks like now. We integrate HIV screening as a routine, regular part of daily emergency department care. And it is, how we do this is we have changed our electronic health record to automatically initiate an HIV order for all adult patients that are getting blood drawn. And we've set the algorithm up so that it will screen a patient once a year, provided the system doesn't identify them as previously being HIV positive or having recently had a test in the prior 12 months. So if I, as a physician, you can see on the screen, order a CBC with differential and then process that order, it will automatically identify eligible patients. And all I have to do is now accept the HIV test order. This is how we've integrated into a kind of a sustainable manner, taking advantage of existing protocols that we do all day, every day. We also screen all patients who are getting an STI test. So if you order a syphilis test or a chlamydia or gonorrhea, the system will automatically order an HIV test as part of that STI panel. So this is kind of the backbone of how the tests get ordered. Our nurses do oral consent at the point of the blood draw. They have pre-labeled specimen tubes and information handout that they give the patients. And we've gotten to the point where we just notify patients that this is a routine part of their healthcare. And today they're getting their annual HIV test. It is as simple as that. The intent of the program is that the results are disclosed during that ER visit by the treating physician. So all of the physicians are trained in kind of the basics of result disclosure, the test characteristics, and really know how to reach out to our linkage team to get patients to the next stage of their care. And we are fortunate to have a team of kind of ED-based linkage staff. And this is the team that basically does all of the work. This is Kelly, Ashley, and Michael, who oversee the program, do care coordination, linkage services, counseling, outreach. They do it all. And many of you on this call have probably worked with at least Ashley and Kelly, because Michael is brand new to our program. So I wanted to kind of introduce the team. So now you actually have a face to the name. And I will turn it over now to Ashley.
Great. Thank you, Doug. And thank you, everybody, for being here today. We've been looking forward to this for a long time. Our team was just talking about this today, how sometimes the easiest part of getting a patient into care is that really early step where we're disclosing the result and initiating rapid ART. And so we thought that this kind of was a nice visual, right, to show this huge network. And even at that, it doesn't include everybody who's here today, but it really does take a large group to help identify these barriers to care. And it's not always easy, but together we are able to link a lot of patients. So I just, do want to highlight that. So given that, we do have, a lot of successes, but we also have some what we would call unsuccessful cases. And so we want to start by touching on a successful linkage. So this patient was a 30-year-old male who came to the Highland Emergency Department after being physically assaulted by an ex-male partner of his. So both as part of our standard HIV testing in the emergency department and as requested by the patient, they were tested for a full range of STIs, and they ended up being reactive to the HIV rapid test. Now, once we got this result, the provider team did an amazing job. They disclosed this result very early on and reached out to the ED linkage team. They began to initiate a rapid start of antiretrovirals, and social services came in to work with the patient to try to get them a safe space to return to after the visit. Unfortunately, the patient did decline, and there was this plan established that as soon as the patient had finished their ER visit, they were going to go straight upstairs for a really nice, just drop-in visit at our adult immunology clinic, the AIC. Unfortunately, this patient did not show up to his appointment. He did obtain his medications, his HIV medications from the pharmacy that day, but never showed up to that appointment. And so both our team, the ED linkage team, and the AIC team made a lot of efforts to try and contact this patient. Unfortunately, we found out that his phone had been broken in that altercation with his partner, and all of the other numbers we had in our EHR were ultimately out of service or just wrong numbers. So pretty quickly, the AIC sent out an address to a letter to the address that we had on file. But unfortunately, our impression largely at that point was that this patient could be lost to follow-up. We had no way to reach them. Luckily enough, the patient did return to Highland about 7 days later. They came to our same-day clinic and they were seen for anxiety. The provider there prescribed them some anxiety medications. And so this is where kind of this magic collaboration happened. So the patient went downstairs to our pharmacy to pick up those medications, and the team down in the pharmacy actually recognized the patient, saw through both the ED team and the AIC team's, documentation in Epic that we had been trying to find this patient and that ultimately he had missed his appointment. And so this team down at the pharmacy took it upon themselves to remind the patient how important it was to follow up and tell them, go upstairs, go visit the immunology clinic. And at the immunology clinic, at the AIC, they were able to take the time immediately to sit down with the patient, offer education, offer emotional support. It was then found out that the patient had an active substance use issue, a disorder. And so he had enrolled himself in a detox program where he had been that whole week. He was lost to follow up for us. So he then transitioned to a sober living environment, became employed, has been undetectable for a while now, and is still in care at the adult immunology clinic. So that was a great success for us. We were super happy. Given that, this is an example of another case that had a lot of great collaboration. Unfortunately, this patient is still lost to follow-up. So I will switch the baton over to Dr. Eric Anderson, who was the emergency department provider for this case.
Thanks, Ashley. I get to talk about the unsuccessful linkage here, but this was a patient that I saw at 2 or 3 o'clock in the morning at the Highland Hospital ED recently. And he presented with some agitation and meth intoxication. And as part of that process, got some blood tests drawn. And one of the, he got his screening HIV test alongside that due to our screening program. The screening test was reactive, and we went to disclose the result to the patient after he had sort of had some medications and was a little bit more calm. And we discovered that he was going to have some really significant barriers to care. He had untreated psychiatric disease. He was homeless and phoneless as well. And as I'm also one of the addiction doctors, I was talking to him about his meth use, which he used really regularly. And he had really no desire to cut back on his meth use at that point in time, but he was interested in potentially receiving treatment for HIV from the emergency department right away. So being that it was 3 or 4 in the morning, we had to, and this patient had a lot of barriers to care. The main option for him was to stay in the ED until the next morning, because during the day, we of course have a lot more services available. And so we kept him in the emergency department overnight. I sent a secure email to both our HIV and substance use disorder teams and asked them to come and see the patient in the morning and perhaps get him as many same-day services as possible, and at least meet this young man and try and engage him as much as we're able to. And then I left for the morning and went to go sleep, and fingers crossed Ashley and her team and our bridge team was going to come see them the next morning. So what happened next, Ashley?
So the next morning, as Dr. Anderson said, the substance use navigators went and visited the patient, offered some counseling, offered their support, reminded them of the bridge clinic's, open door policy for patients. The immunology clinic also came down and really just had this beautiful interaction with the patient. Tanya Tyree, who's now unfortunately not able to be here today, did a really amazing job of getting the patient to kind of open up and discussed, starting rapid ART that day and reviewed the medications and offered the patient a follow-up appointment for, I believe it was the next day. And so she did really make that connection with the patient. And the plan was just, okay, you don't have a phone and you're homeless, so you have to show up, and so the patient agreed to that plan. Next slide. Great. So unfortunately, this patient did not show up and we just didn't have a way. Yeah, Sophie, we love Tanya too. We didn't have a way to reach this patient. And so we hoped he would show up, but he has not. So we notified Georgia Schreiber, who we also love at the Alameda County Public Health Department. And Georgia did some work on the back end that was super helpful and spoke with some colleagues at the SF Public Health Department who were able to actually see that this patient has been in San Francisco a lot and has been tested for HIV in San Francisco. So we have some alerts put out if the patient does return to these same testing sites. We're going to try to continue to collaborate and get this patient into care, but it is a difficult case for us, one where we couldn't fully overcome all of the barriers to care. And so that's our challenging case.
Eric, I've turned it back over to you.
Okay, great. So we'll just go right into our next presentation here. So my name is Eric Anderson. I work in the emergency department at Highland Hospital and Alameda Hospital, and I also work as one of the addiction medicine providers in the Bridge Clinic. And I'm hopeful that some of you have I know that we have interacted with some of you folks on the presentation here, so I'm excited to talk a little bit about our services and a general approach. So looks like you can see my screen. So I'm going to talk about substance use broadly and sort of the general scope of the problem as a really quick overview, and then get into a discussion about the Bridge program and substance use treatment services at Alameda Health System. And then briefly go over some treatment and harm reduction approaches. And the main message I want to get across is how to get a hold of us in the Bridge Clinic. And so there's a couple spots where you'll see that, as well as on the East Bay Getting to Zero website. So we are, the main message here is that we are available for anybody in the community to engage with treatment services if that's what you're looking for. So many of you may be seeing a slide similar to this, but it's no secret that nationally, overdose deaths have been increasing over the last 10 or so years pretty significantly in several different waves. This most recent wave of opioid overdoses has been mainly attributable to fentanyl. A lot of folks talk about a fourth wave of overdose deaths attributable to methamphetamine overdoses as well. I guess I went a little early here, but that's okay. So one thing to think about is how this has changed during COVID-19. There's been some press articles about increasing alcohol use and increasing substance use and also increasing overdose mortality during 2020. And there's a lot of really complex and probably understandable reasons for some of these increases in unhealthy substance use and overdose deaths. So these are just some states that were able to report data on overdose deaths, and California, to no surprise, has had an increase in 2020 compared to the year prior in overdose deaths during the COVID-19 pandemic. And this has received some attention and resources over the last couple of years. Interestingly, when we think about like these third and fourth waves of overdose deaths, methamphetamines and fentanyl, they're both we need to engage both these substances really proactively, but there is this really remarkable sort of like regional variation. On the East Coast, they had fentanyl far before we did. So we were talking to colleagues a couple of years ago and hearing about all this fentanyl. We weren't seeing it as much here, but we were seeing an awful lot of methamphetamine use. And that's just the reality. Not totally exactly sure why, but we do see a lot of meth use on the West Coast, and we're starting to see a lot more fentanyl use as well. This is just a statistic I like to note that in 2020 in San Francisco, there were 621 people that died from drug overdoses, and 173 people in 2020 that died from COVID-19. So substance use and HIV, these are intertwined, as we all know. There are higher rates of HIV among patients who are using injection drugs, and there are also higher risks of HIV among patients with unhealthy alcohol use. And some of this is the mechanics of substance use, and some of this is risk behaviors, sexual risk behaviors, as well as other risk behaviors that increase the risk for HIV. Methamphetamine use, I know that a lot of folks want to talk a little about, and hopefully we can talk more in the small groups too. But methamphetamine use disorder and HIV risk are also really intertwined. There are higher rates of meth use among men who have sex with men. Meth use is associated with an increased risk of HIV due to risky sexual behaviors, but also probably due to some impaired immunity with chronic meth use. And among people living with HIV, meth use is also associated with worse outcomes. So when we think about HIV prevention and substance use, we want to think about these things as intertwined programs at Alameda Health System and in the emergency department. So our ED-HIV linkage team collaborates on cases with the substance use navigators. When one team identifies a patient that might need the services of the other, these folks are collaborating on Epic with cell phone texts and with just getting these folks connected to whatever services they might need. Our substance use navigators will see patients and make sure that those patients, if they're not getting automatic HIV and hepatitis C testing, can be tested by the ED, regardless of whether it was automatically triggered. And then lastly, while we're co-locating these linkage services, we also want to co-locate, if needed and as much as possible, some treatment services as well. And in the last year, we started to treat HIV in collaboration with our colleagues in the GI division in the Bridge Clinic. And we've had a couple patients on PrEP now in the Bridge Clinic as well. So now I'll go over a little bit about the Bridge program, and hopefully Dr. Ulal can chime in here, who's the Associate Medical Director of the program and joined us today too. I want to put out this website, highlandbridge.org. This is our team, and it emphasizes that we're engaging patients with any substance use, opioids, alcohol, stimulants, anything we are able to engage with. And the substance use navigators, here's two of them, Zaire and Kelvin, and they really are the foundation of our team and a main access point for patients in the emergency department as well as in the community. This website obviously is available, and then this is the cell phone number of how people can get in touch with this team as well. Monish, maybe you want to jump in here and describe sort of the overview of the Bridge program and some entry points?
Yeah, sure. Hi, everyone. My name is Monish Ulal. As Eric said, I'm the Associate Med Director in the Bridge Clinic. So in terms of, what the Bridge Clinic program, how it's structured, the sort of the fundamental core of the clinic is our substance use navigator team, or the SUN team, the SUN team. And what we do is have all of these touch points in the community, whether it's residential treatment programs, whether it's emergency departments within our health system or outside of our health system, or the Santa Rita Jail, or FQHCs, the CHCN, our detox center in the county, Cherry Hill. All of these places, the goal is that they all know that there's this universal entry point through the substance use navigator, primarily that cell phone listed here, which we'll be repeating a lot on these slides. And that with that phone number through the substance use navigator, patients and providers alike can get direct same-day access to substance use disorder treatment, and really being medication first in terms of our structure and offering medications for addiction treatment like buprenorphine with like expediency, like same day as much as possible. Our program has like the medical clinic, which offers the MAT or MOUD. And we also have a fairly robust behavioral health arm, which includes like licensed clinical social workers to offer like linkage to long-term therapy and therapy within the clinic, as well as an intensive outpatient program that we call the Substance Use Disorder Treatment Program, that includes like counseling services, therapy, like career counseling. We even had a daycare running before COVID. It was open 5 days a week. There was like lunch 4 days a week. Some of that is on pause due to COVID, but lots of services that are available presently. So that's sort of a general overview of the program. So in terms of how the substance use navigators work, the goal is that there's sort of a hybrid role of like a linkage coordinator, a peer support counselor. There's sort of like a medication access coordinator person. They're also like sort of a medical assistant when they're working in the clinic, or sort of all of these things in one. And the idea is that they're someone who is a friendly and accessible face for our program to patients, that is like reliable and really, really accessible to patients and providers. And it's important to us, for example, that cell phone number that patients can call or text, there's a human being that answers that phone, and it's one of our substance use navigator team members. And a lot of our patients, they refer to our clinic as the Sun Clinic, or providers might refer to it as a Sun Clinic, because they're really the heart of our program. And so they can identify patients or link patients at the bedside, whether they're in the ER or the inpatient side or in the clinic. They can communicate with patients same day, link them to a provider or access to medications, for example. A huge part of what they do is navigating like pharmacy barriers to access to medications, and helping patients never go without buprenorphine, for example, if they were on buprenorphine for opioid use disorder. So I think those are some of the important roles that they have. So in terms of, a few more details about our services, we have same-day linkage, like I mentioned, to our providers and our navigators. We really try to have like this very low barrier structure where patients can come in pretty much anytime, Monday through Friday, like 8 to 5, essentially 8 to 6. And there's really no appointments necessary. They can walk in physically. They can sort of virtually walk in by virtue of just calling the navigator and asking to speak with a doctor, or asking to get help with identifying an issue related to substance use disorder treatment. And once we engage patients, we can get them started on MAT. We can link them with behavioral health treatment. As Eric mentioned, we can offer Hep C treatment integrated with our clinic, and PrEP. And we're starting to roll out contingency management, which is a fairly effective behavioral health intervention for patients with methamphetamine use disorder that we're really excited about. And that's coming within the next 1 to 2 months. And then we have these behavioral health services that I mentioned earlier. Yeah, go for it, Eric.
Okay, I know we only have a couple minutes left, so I'm going to really quickly go over the main treatment and harm reduction approaches. So buprenorphine for opioid use disorder, I'm sure that you've all heard of patients or taking care of patients who are taking buprenorphine, but it's really a wildly effective medication in preventing mortality and engaging patients in care, as well as reducing transmission of HIV and hepatitis C. So this is sort of really the backbone of a lot of the care that we provide in the clinic, just mostly because it's such like I said, a wildly effective medication. Here we just want to emphasize that there is a care cascade for buprenorphine. We view medications as the standard of care. We want to have a low barrier for patients accessing medications for opioid use disorder. And we wanted to talk a little bit about meth specifically. And, methamphetamine use disorder is a difficult disease to treat. There have been a couple interesting advances in the last several years. These 2 papers, I just wanted to highlight these main treatment options that we will use for patients who are using meth. There was one study a couple years ago in JAMA Psychiatry that showed that using mirtazapine reduces meth use and high-risk sexual behaviors in men who have sex with men and transgender women who have sex with men. And then a second paper came out this year showing that we could use these other 2 treatment options, naltrexone and bupropion, to reduce meth use among all patients. And so we've really, these are, it's not a robust body of evidence, but we have been using these treatments quite often. And I think anecdotally, we've both seen a lot of success for a lot of patients with these treatment options. And again, we can't emphasize this enough that for stimulant use disorders, especially, that the engagement and co-location that our medical clinic has with the substance use treatment program is really critical for patients, so they can have access to groups, individual therapists. You know, we're really excited about this contingency management pilot and the intensive outpatient program. Our priority is always engagement, and this is the segue into the harm reduction portion that I'm going to spend 2 minutes on. I'll be done, I promise. We really want to have a compassionate, safe space for patients to drop in at any point, and regardless of whether or not they're ready to stop using substances. So you guys all know about harm reduction. We have harm reduction kits that are available in the ED and throughout Alameda Health System hospitals, the inpatient settings too, that have safe injection kits, condoms, naloxone, as well as a sharps container. And we're excited about a partnership that we'll have with HepPAC as well coming forward. We also talk to patients about harm reduction for alcohol. In the future, we're hoping to try and develop syringe access out of the ED as well. So this is just emphasizing that we do want to prioritize so much engagement and care for patients regardless of where they are in readiness to stop using. And this is the last slide I'll leave up for a couple seconds about sort of a flyer of how you can get a hold of us.
Great, thanks, Eric. And actually, the link has the flyer as well. You can see the link from our service directory has a link to the flyer, and also you guys have your website, which is posted as well. Quickly, Eric, before and Monish, before we break into small groups, any tips that you have for the initial linkage phase for somebody who is using methamphetamines? Like, what are some ways that we can get them to substance use treatment? Because we see them before they get to you. Do you have any advice or guidance for that part of the process?
Yeah, I think that always a priority is engagement somewhere, and you know, some of this is empowering wherever patients land, that you can engage patients with their substance use disorder. It's totally reasonable to offer these treatments for patients, and we're always available. Like if a patient's like, I love coming to this clinic, I love coming to this space, which we see a lot in our clinic, and that's going to happen elsewhere too. That if the providers want to call us about questions about medications, or if the patients just want to call and see what's going on, I think that's always an option and super, super reasonable. Really, any point you interact with AHS, and you have a substance use disorder, we want that substance use navigator, the SUNS, to be able to interact and help with patients too. So all of these are access points. Granted, we know it's the acute care system really, and not all patients are that excited about that. But this number, this 510-545-2765 number, call, text, and it's very available. It doesn't matter what your insurance is or no insurance. We'll be able to get essentially same day access for anybody who wants to talk to one of us at any moment, any day. If you had anything to add, Monish?
No, I think that's exactly it. Like I would say, offering patients this phone number, telling them call us or text us at that number, offering them medications where they are, like sort of this no wrong door approach, where they don't have to wait to see us in the Bridge Clinic to get engaged in treatment. That you can do it with them, and we can empower you to do that with a quick phone call or just checking out the website or whatever is easiest. So just keeping it as easy as possible for patients.
Great, thank you for providing that awesome service. So we're going to take any other questions in the large group after the small groups. I'm going to paste in here. So thank you all, Doug, Ashley, Eric, and Monish. Thank you so much for all of that rich information. I'm going to paste into the chat the breakout room questions. Now, if you don't have cases or questions yourself, these are the backup cases, are the ones that we've already discussed, that Doug and Ashley introduced to us, and Eric talked about as well. And then we have some questions in case you don't have questions yourself. So we're going to break up into small groups, thanks to Jessica helping us do that. I also put in links around the handout, which has the case that have the cases in them, as well as links to the ED team information and the SUN, or the Bridge Clinic, information here. And then finally, our housing workshop in October. So Jessica, do you want to help us get into our small groups now?
Yep, you guys are ready to go. I'm opening them now.
Thanks all.
Thanks.
See you in the small groups. We will now do some lightning rounds around sharing. And Jessica, this is where I'm going to need your help just to identify who the small group facilitators are. So first group, we're going to do lightning rounds on highlights from our small group. So strategies that you want to share around strengthening ED and substance use linkages. So first group, let's see. Jessica, was Doug one of the group leaders?
Yes, he was.
Okay, great.
Yeah, so our take home for our group, I think that people recognize that the perception that doing this work in an emergency environment is reality, that it's difficult and that it's not going to be perfect, and that our system is not actually designed for this. And as a result, the people that are doing the linkages basically have to pick up the slack and work with an imperfect system. And that requires dedication and a commitment, and sometimes thinking creatively and outside of the box. And my group had, stellar linkage people that kind of were like, oh yeah, this is just what we do. And I was like, no, what you do is so unexpected and so much from our standpoint above and beyond to get people into care that we just recognize that, yeah, the ED system is not geared for this, and our protocols aren't perfect, and that you guys have to often pick up the slack and do things that are maybe outside of your daily kind of routine linkage practices.
Yeah, for sure. So being creative and doing the above and beyond commitment, beyond protocols is basically what you're saying, right?
Yeah, because an emergency department is it is a non-traditional testing venue for a reason, because it's not what we are designed to do, and we don't have all of the resources that some of your systems have.
Yeah, thanks. Which is why we're doing this together. So thank you. Yeah, and thanks to all of you all who are doing that creative above and beyond commitment. All right, Sunny, did you have a group?
I believe she did.
Okay. Is Sunny still with us? Okay, we'll skip Sunny for now. Kelly?
Yeah, so my group talked a lot about how important it is to have a reliable point of contact in order to collaborate effectively, but also how it's also important to communicate your shared goals around addressing stigma and barriers with that collaborator. That way the patients can receive what they need, like services and education at every step along the way of their linkage journey.
Right, so having a reliable point of contact, which is why we want you to make sure your directory entries are correct and up to date, and make sure you communicate shared goals for the client so that we're actually providing the services that they want. Great, thank you, Kelly. Okay, great. Ashley.
So we had a wonderful discussion about a few different things. I think two big takeaways that we had. I know I'm only supposed to do one, but one was just the need to kind of continue to be sensitive in our conversations with our patients. Sometimes it's easy to say, oh, I heard you were at this clinic and you worked with this person, and that can sometimes make a patient feel even more vulnerable, just knowing that their information is out there. And so there was that, and also just kind of this need and emphasis on being willing to have difficult conversations with patients around what it's going to take to get them into care. And whether that's getting them a cell phone or a bus pass or, anything like that, gas cards, and really being able to address those barriers head on in a way that makes the patient feel comfortable.
Right, so being sensitive around what information you share with the client and about the client, and then willingness to have difficult conversations around what they need, which sometimes may feel embarrassing or shameful for somebody. Great, thank you. Okay, Eric?
Yeah, we had a great conversation, and I think that some of the big takeaways were leveraging these existing resources within the community, like healthcare for the homeless, different clinics and pharmacies. And when you're looking for someone with these alerts, making sure that one of the specific things you ask for is an updated phone number, or point of contact. And then also to make sure that you know, some organizations have this, I know some others don't, but to integrate people with lived experience and peers into the process. And so, you know, some places may or may not have that resource, but how powerful that can be for folks.
Great, thanks. So leveraging existing resources, making sure you have updated phone numbers for the client, right, Eric, or for the organization? Both, probably. And then integrating peers into the process. Awesome. Okay, Monish.
Yeah, so our group had a great discussion, and I think some of the highlights were this idea of sort of meeting people where they're at, whether that's physically, like in the community, and if they're not meeting you in your clinic, but also just in terms of like what their shared priorities are, and like sort of being patient-centered about what a patient's goals might be and how those might differ from our own when we're engaging with someone. And then what a lot of folks have already said, sort of leveraging our shared resources, utilizing like this network that we're building with discussions like this to help provide services to patients wherever they are.
Great. So utilizing the network to meet people where they're at physically, but also sharing priorities, recognizing their goals, which may be different from your goals. Okay, great. Thank you. Yamini.
Yeah, so much of what we discussed has been touched on. Shout out to Dante, Alex, Michelle, and Kevin. One thing that came out of our conversation was actually to take the time, though this feels very rushed, right? Linkage feels like a very rushed process, but taking the time to really learn and understand the person we are trying to link. Also really leveraging, again, those resources of getting people phones and vouchers. And if we have to apply for funding, that is no strings attached to be able to do that, then that's something we need to think about on a programmatic level. And then, yeah, I think that's pretty much it. And then we also mentioned a little bit about the Children's Hospital ED. It's there are some different issues there. There's linkage that needs to be talked about in that environment as well, but adolescents face a couple of additional or different challenges. And so we began discussing those too.
Great, thank you. Okay, so taking the time to understand the person and meet their needs, whatever it is, and being having less strings attached to some of those resources that we give to folks. Okay, Sean.
Yes, hi. So we went a little off grid. We didn't talk about the ED because the case that came up from one of the members in the group didn't, but it still applies because the person was struggling with substance use disorder. And so one of the largest takeaways is that how important communication and collaboration between providers is important, like talking things out, but also with the patients when you have them engaged. Because this particular case was about a patient that was engaged and then got lost to follow-up, and now it's still kind of out there. And we were kind of problem solving around what would be some strategies to locate and re-engage this person. I also want to just echo what Eric said about, it also came up in our discussion about the importance to clients and patients of having people with similar lived experiences as they do, especially if you have someone that has a substance use experience or same sexual or gender minority experience as that person. Those things were discussed. And again, yeah, as Yamini said, understanding that patient is really important to get as much information as you can, that if they do get lost to follow-up, you would be able to find them.
Great, thanks, Sean. So having communication and collaboration between providers, especially for ongoing problem solving, because things will come up, having more people who with similar lived experiences supporting the patient and also taking the time to understand them. Sunny, are you there? Is there anybody else left, Jessica, besides our group, my group?
I think that's it. I think there are a few people from Sunny's group here if they'd like to share. I think Allison, Steve.
Anybody want to share a highlight from Sunny's group? Or you could type it into chat.
One of the things that we had discussed is using our EHR to help us find patients. We're able to see if people have had ED visits. We can see if they have upcoming appointments at other clinics or other departments as well. So that's something that's definitely been helpful to try to engage patients.
Great, thanks, Allison. So I'm going to piggyback on you. It's perfect segue, Allison, because our group actually talked about adding, if somebody is out of care, adding that to their problem list, because it sounds like a lot of folks, they may ignore alerts in Epic, but they'll actually look at the problem list. So really think about adding basically case manager contact info in problem list. And that way, it might be more likely for a provider to see that they might be out of care and that they should call this case manager to get them back in HIV primary care. So that's one useful thing. And the other thing that came up for our group is meeting people where they're at and literally having telehealth resources at encampments and shelter sites. So bringing food, bringing phones, bringing solar chargers, transportation and gift cards, basically kind of bringing resources to the person where they're at and making it possible for them to engage in care literally where they are physically located. So that's what we would like to add from our small group. All right, we've got a couple minutes left together. I know, Ramon, you had one question for the bridge team. Do you want to ask that real quick? I think there was a question about somebody having trouble getting into care with the bridge team. So I don't know, Ramon, if you want to ask that in the last couple of minutes, and then we'll close up with evaluations.
Sure. I'm just curious as to how COVID is affecting numbers and access for clients into Bridge and into that whole linkage system for people with substance abuse or substance use issues, because numbers are having to be really low. We had a client that had to go through Cherry Hill, and even access into that linkage for inpatient or outpatient services was hampered because of COVID. Attempting to gain resources through Bridge didn't necessarily work, so we had to kind of do the work ourselves to get them into some sort of care. So I'm curious as to how that's affecting the process for you.
We've been still done in-person appointments for those folks who need to do them all throughout the pandemic, and you can always drop in. So, you can always tell a patient to just like go to Bridge Clinic. So I'm sorry to hear that it was a little bit difficult. I'd actually be curious to know what exactly the issues are so we can work on those, because we do sort of pride ourselves on being as low barrier as possible and for folks. But our numbers we are very, very busy, and the in-clinic and the outpatient treatment program, though, has been, a lot of it's been remote, so we haven't had groups. And so that's probably been affected more than the clinic side of things. And if you want to add anything, Monish.
Yeah, I would say that, during COVID, we obviously flipped to a lot of telemedicine, by which I mean predominantly telephone visits. Probably 85% of our patient contacts are telephone. And as Eric said, fully open for business in terms of walk-ins. Definitely would love to try and troubleshoot some of the pain points for folks. I think that, sort of speaking to the cascade of care graph that was in Eric's slides, so many of, we try so hard to engage patients, and sometimes a lot of patients especially with severe substance use disorders, they're really early in that cascade of care where they're in the sort of engaging, re-engaging, losing engagement, re-engaging. And we recognize that is really challenging, but also a pretty standard part of the sort of care continuum for the patients that we see.
Great, thank you. So slides from today. Oh, Steve, I don't know if you're still on for a minute and you want to share what's happening with partner services in Georgia. Steve may have needed to drop off. Okay, we will provide those updates to the network in terms of, since Georgia is now full-time deployed for COVID, how to do some county linkage work. So Steve will hopefully give us some updates. We'll share that with the group. And then finally, it sounds like Eric and Monish, for Ramon to follow up on this particular client, would it be useful for them to call the Sun number, the phone number that we provided, and do some like troubleshooting with you, just in terms of follow-up?
Yeah, sure. And I'll put my email in the chat. So whoever would like to email me, please, very happy to be available, however we can be helpful.
Okay, great. Thank you so much for your openness and willingness to share that. And finally, as people wrap up here, just want to remind you of our upcoming meetings, and then also if you could please click on the evaluation link that Jessica put in the chat, that would be really, really helpful. And if you just want to put into the chat what was most helpful or useful for you today and anything you want us to do next time, that would be great. Just like quick feedback to put into the chat. We take your feedback very seriously and we do things with it. So please share. And I just really want to thank the ED team and the Alameda Health Systems team and the Bridge team for coming and presenting and sharing your wisdom and your services with us. And hopefully we will, as we get to know each other over time and continue these collaborations, all of these things will strengthen. I will put together all the highlights that folks shared from the small groups and send that out with the follow-up notes. And Bridge team and ED team, if you're willing to share your slides, folks have been wanting to have your slides. I will put them in a PDF handout if you're okay with that. If you can email them to me, that would be great, in whatever format you're comfortable with sharing. Is that cool with everybody?
Yep.
Awesome. Thank you so much. And we'll send out, again, notes, highlights. I will put the highlights in the slides, and then we'll put together all the handouts from everything. And again, here's the eval link. And thank you so much. Stay safe, stay well, everybody, and stay sane. Take good care of yourselves.